If you have ever been prescribed amlodipine, losartan, or lisinopril for high blood pressure, you may feel confused about which one is better, how they work differently, and what they are really doing inside your body every single day. This confusion is completely normal because most patients are only told, take this tablet daily, without being fully explained what is happening behind the scenes in their arteries, heart, kidneys, and hormones. But understanding these medications is extremely important because hypertension is not just a number problem, it is a slow damage process that affects almost every major organ silently over years. Before we compare these three medications, you need to understand what high blood pressure actually means in simple terms. Your heart is a pump and your blood vessels are pipes. When the pressure inside those pipes stays too high for a long time, the inner lining gets damaged, small injuries form, cholesterol starts depositing, and over time this increases the risk of heart attack, stroke, kidney failure, and even vision loss. Now the goal of medications like amlodipine, losartan, and lisinopril is not just to lower a number, but to protect these organs by reducing pressure and preventing long-term damage at the cellular level. Let's start with amlodipine in more detail. Amlodipine is a calcium channel blocker, specifically a dihydropyridine type. In simple biological terms, calcium is what helps blood vessels contract and become tight. Amlodipine blocks calcium entry into smooth muscle cells of the arterial wall, which causes vasodilation, meaning your arteries relax and widen. When arteries widen, resistance decreases, and your heart does not need to push as hard. This is especially important in older adults where arteries naturally become stiff due to aging and atherosclerosis. Amlodipine is very effective for controlling systolic blood pressure, which is the top number and is often elevated in elderly patients. One major advantage is that it provides 24-hour smooth control because it has a long half-life, meaning one dose can work throughout the day and night. However, because it dilates peripheral blood vessels, it can sometimes cause dependent edema, especially swelling in the ankles and feet. This is not due to heart failure, but due to fluid shifting in the small capillaries. Some patients also experience flushing, mild palpitations, or gum enlargement in long-term use, although that is less common. Despite these side effects, amlodipine is considered very safe and widely used globally because it does not significantly affect kidney function or blood sugar levels. Now let's go deeper into losartan, which belongs to the ARB class, angiotensin receptor blockers. To understand losartan, you must understand the renin-angiotensin-aldosterone system, often called RAAS. This is one of the most powerful blood pressure regulating systems in the human body. When blood pressure drops or kidneys sense reduced perfusion, they release renin, which eventually leads to production of angiotensin II. Angiotensin II is a very strong vasoconstrictor. It tightens blood vessels and increases blood pressure rapidly. It also triggers aldosterone release from the adrenal glands, which causes sodium and water retention, increasing blood volume and pressure further. Losartan works by blocking the AT1 receptor, meaning angiotensin II cannot bind and activate its harmful effects. As a result, blood vessels remain relaxed, sodium retention decreases, and overall blood pressure reduces in a more physiological and protective way. One of the most important benefits of losartan is its kidney protection, especially in diabetic patients with proteinuria. It reduces intraglomerular pressure, which slows down kidney damage progression. It also has mild uric acid lowering effects, which can be helpful in patients with gout. Compared to ACE inhibitors, ARBs like losartan have a much lower risk of causing dry cough because they do not increase bradykinin levels significantly. Side effects may include dizziness, especially in the first few days, and rarely elevated potassium levels, hyperkalemia, which is why periodic blood tests are recommended. Now let's go deeper into lisinopril, which is an ACE inhibitor. Lisinopril acts earlier in the RAAS pathway by blocking the angiotensin converting enzyme ACE, which is responsible for converting angiotensin I into angiotensin II. By blocking this conversion, lisinopril reduces angiotensin II levels significantly. This leads to vasodilation, reduced aldosterone secretion, decreased sodium and water retention, and ultimately lower blood pressure. One of the most important clinical benefits of lisinopril is its strong evidence in improving survival in heart failure patients and after myocardial infarction, heart attack. It reduces cardiac remodeling, meaning it helps prevent the heart from becoming weak and enlarged over time. However, ACE inhibitors have a unique side effect profile. The most well known is a persistent dry cough, which occurs due to increased bradykinin levels in the respiratory tract. In some patients, this cough can become very uncomfortable and may require switching to an ARB like losartan. Another rare but serious side effect is angioedema, which causes swelling of lips, face, or airway and requires emergency attention. Like losartan, lisinopril can also increase potassium levels and affect kidney function in certain conditions, especially in patients with dehydration or bilateral renal artery stenosis. Now, the most important clinical question: how do doctors choose between these medications? The answer is not random. It is based on evidence, patient profile, and comorbid conditions. If a patient has isolated systolic hypertension, especially older adults with stiff arteries, amlodipine is often preferred as first-line therapy. If a patient has diabetes, chronic kidney disease, or protein in urine, losartan or lisinopril is preferred because of their organ protective effects. If a patient has heart failure or post-heart attack condition, lisinopril is often strongly indicated due to its mortality benefit data. In real clinical practice, many patients require combination therapy because hypertension is multifactorial. A very common and effective combination is amlodipine with losartan or amlodipine with lisinopril. This combination targets two different mechanisms: vascular relaxation from calcium channel blockade and hormonal suppression from RAAS inhibition, leading to better blood pressure control with lower doses and fewer side effects than high-dose monotherapy. Another very important concept is that these medications do not work like painkillers. You will not feel them working, but inside your body they are continuously reducing stress on blood vessels, preventing endothelial injury, reducing left ventricular strain, and protecting microcirculation in kidneys and brain. This silent protection is the real goal of therapy. Long-term adherence is critical because stopping and starting medication can cause blood pressure variability, which itself increases cardiovascular risk. Along with medication, lifestyle modification plays a massive role in improving outcomes. Reducing sodium intake below recommended levels, increasing potassium-rich foods if medically safe, maintaining regular aerobic exercise, managing sleep quality, reducing alcohol intake, and controlling stress through relaxation techniques all contribute significantly to blood pressure reduction. In some patients, these changes can reduce medication requirements over time, but they rarely replace medication completely in moderate to severe hypertension. Home blood pressure monitoring is another crucial tool. It gives a more accurate picture than occasional clinic readings because blood pressure fluctuates throughout the day due to stress, activity, sleep, and diet. Proper monitoring helps doctors adjust medication more precisely and avoid overtreatment or undertreatment. It is also important to understand that these medications are backed by decades of large-scale clinical trials involving hundreds of thousands of patients. They have consistently shown reduction in stroke risk, heart attack risk, heart failure progression, and kidney disease progression when used appropriately. That is why they are considered first-line therapies in international guidelines. Finally, if side effects occur, it does not mean you have to suffer or stop treatment. Medicine has alternatives within the same class or different classes that can be safely substituted. The key is proper follow-up, communication, and individualized treatment planning. To conclude, amlodipine, losartan, and lisinopril are not just blood pressure pills. They are organ protective therapies designed to reduce long-term cardiovascular risk and improve lifespan quality. Each one works through a different biological pathway, and each one has specific advantages depending on the patient's condition. The most important thing is not which drug sounds better, but which drug is most suitable for your body and your medical profile under proper medical supervision. Always take your medication regularly. Never adjust or stop it without consulting your doctor. And remember that controlling blood pressure is one of the most powerful steps you can take to protect your heart, brain, and kidneys for the future. If you found this video helpful, make sure to subscribe to the channel, like this video, leave your questions in the comments section, and share it with someone who needs this information, because awareness and understanding can prevent serious health complications and truly save lives.